I'm Dr. Bob Bartlett. In this session, we are going to look at the risks and side effects of hyperbaric oxygen therapy. Perhaps of all the sessions, this one is the most important because this one is about assessing risk versus benefit and above all, keeping things safe for our patients. So let's get started and look at the first topic here, which is the absolute contraindications for hyperbaric therapy. The first absolute contraindication would be an untreated pneumothorax. Now, if you have completed the physics section and studied Boyle's law, you could understand why an untreated pneumothorax would certainly be a contraindication. In accordance with Boyle's law, if a pneumothorax at depth begins to re-expand as we approach the surface, and again, moving from 2 ATA to the surface, we would drop the pressure by 1/2, which means the volume would double. We could easily convert a simple pneumothorax into a tension pneumothorax. Now, if the pneumothorax has been treated with, say, a chest tube, with a Heimlich valve or a flutter valve, then one certainly could proceed in treating these patients. But again, an untreated pneumothorax is considered an absolute contraindication. Now, the next one on our list of absolutes would be the medication called adriamycin or doxorubicin. This is a medication that is used in the management of cancer. Under normal conditions, it has a known association with cardiotoxicity, but under hyperbaric conditions, notice the mortality in animals is as high as 87%. And therefore, HBO is absolutely contraindicated if a person is actively receiving this drug. Now, the mechanism is thought to be through an oxygen potentiation of free radicals. And these oxygen-free radicals have an enhanced anti-tumor effect. We'll study more about oxygen-free radicals when we talk about oxygen toxicity. Now, if your patient is off of this medication, then one can certainly go ahead and provide hyperbaric therapy. Typically, they need to be off of this medication for at least a week to 2 weeks. You should always check with your pharmacist to ensure that you understand the half-lives, because half-lives are probably the safest way to think about these drugs. And we'll talk about half-lives here in the next medication. And that next medication is a drug called cisplatin or carboplatin. This too is a medication that is used in the management of cancer patients. Now, the side effect of cisplatin is not something nearly as dramatic as the cardiotoxic effect of adriamycin. But we do know animals that are receiving concurrent HBO with cisplatin, their wounds are not as strong. So if there is a diminution in the strength of the wound, it will be weaker than it would be otherwise. Again, if we allow 6 half-lives to pass, then we essentially eliminate 99% of the drug. Now, here is the half-life concept, well established in pharmacology. In the first half-life, 50% of the drug is gone. In the next half-life, half of that will clear, so you have 25% remaining. In the next half-life, it's 12.5, 6.25, 3, and then essentially 1%. So 99% of the medication is eliminated with the passage of 6 half-lives. And it's probably safest to talk with your pharmacist to know what the half-life is for the medication, because unless you're a practicing oncologist, these medications are always changing. And the general trend of the pharmaceutical industry has really been to make drugs last longer. For example, they could introduce carboplatin XL. And unless you're a practicing oncologist, you may not know they changed the half-time. So let's put this to use. Let's say that you call the pharmacist and they say the half-life is 4 days. Well, 6 times 4 is 24. I'd probably tell that patient, come back in about 4 weeks, and then we could proceed with HBO. On the other hand, let's say that the half-life is 7 days. 6 times 7 is 42. For that patient, we might tell them to come back and say 6 weeks before commencing with hyperbaric therapy. Let's move on here to the next absolute contraindication. The next medication is a drug called bleomycin. Now, bleomycin is also used in the management of cancers. It was originally looked at for an antibiotic effect, but was found to be far more effective in terms of cancer and tumor management. Now, today it's used primarily for the management of head and neck tumors, and in particular for lymphomas and testicular tumors. The concern about bleomycin is based on the phenomenon of bleomycin-induced pneumonitis. This is like an interstitial fibrosis. There have been case reports of individuals who have just been exposed to a modest FiO2, fraction-inspired O2, of 32 to 45% that have developed this kind of pneumonitis. Now, it is idiosyncratic, which means to say we cannot really tell who will be affected by this or when. However, it is still something that is an ongoing concern in medical practice. So, at least in the past, it has been taught that any history of exposure to this drug should be considered a contraindication. For example, even scuba divers really should not be cleared, because as you go down in the water column, you're increasing the gas pressure. And again, if we think about Dalton's law, the partial pressure of the gas, with every 33 feet we move from 0.21 at the surface to 0.42 at 33 feet. If we go a little deeper, we are at 0.62 at 66 feet. Basically, that is a surface equivalent of breathing a 60% venti mask. And as you noticed, we have case reports of individuals with only 32 and 45% developing an interstitial pneumonitis. So scuba diving is really considered to be a contraindication if the patient's had a prior history of bleomycin. So the way this might play out in practice is you're taking the history of a scuba diver or perhaps a patient with a non-healing wound. They're 35 years of age. You ask them if they've ever had any medical problems. They say, well, yes. Let's say it's a male, and he says, you know, when I was 15, I had a testicular tumor. Well, knowing that testicular tumors might be managed with bleomycin is useful. So you'd certainly want to check that medical record. However, this whole concept of bleomycin now is being reviewed, and many authorities now are perhaps recategorizing it from what is an absolute to perhaps what is a relative contraindication. So as you look at textbooks, you may wish to check the date. What is the basis for this changing concept? Well, the basis for changing absolute to relative is a result of some work out of Duke University. Here they noticed a series of 11 patients were treated with hyperbaric therapy, and they had all received bleomycin. These individuals did very well. In fact, only one of the 11 patients developed a problem. The symptomatology was one of some chest discomfort. They noticed there was a decrease in the carbon monoxide diffusion capacity of the lung. Upon stopping HBO, the patient promptly recovered, and they were actually able to successfully complete further hyperbaric therapy by adding air brakes. Now, we'll talk more about air brakes in the session on oxygen toxicity. If you wish to read the report, there, of course, is the reference at the bottom of your slide. Now, perhaps one of the best reviews on this whole issue of bleomycin-induced pneumonitis was published recently in the Journal of Chest in 2001. Now, the authors in this study noted that perhaps the best pulmonary function test is to really look at the lung volumes. And this might actually be more sensitive and more specific than the carbon monoxide diffusion test. Now, there are no proven treatments for bleomycin-induced interstitial pneumonitis, although corticosteroids are widely used. And patients certainly can and do survive bleomycin-induced pneumonitis. And when they do recover, they almost always normalize their lung functions. So this is really a changing concept here, and I suppose, at least from a standpoint of informed consent, if your patient has had bleomycin, it's probably very important that you do make them aware there is a possibility for this pneumonitis. It is rare, it is idiosyncratic, and most assuredly they should probably be followed very closely with pulmonary function tests. Again, Lung volumes may be the best indicator to determine early onset. Prompt cessation of HBO hopefully will lead to recovery. So depending upon what textbook and where you're reading, you may find some conflicting opinions. But again, there is a changing opinion on this matter, and some of the newer evidence suggests that perhaps HBO could be provided on a very cautious basis, always ensuring that the patient has been informed of the possible risks and unknown risks. Now, the next medication on our list of absolutes is a medicine called disulfiram, or Antabuse. This is a drug that was developed to manage alcoholism. And when you take this drug, you are asymptomatic provided you don't drink any alcohol. If you drink alcohol, you become violently ill. So the thought was in designing this drug is it would prevent impulse drinking. If you happen to have a patient who is on Antabuse and they're exposed to hyperbaric oxygen, they are at an increased risk of seizure. As you'll note in the first bullet, disulfiram, or Antabuse, blocks superoxide dismutase. Now, we haven't talked about oxygen toxicity yet, but with a name like superoxide dismutase, it would lead you to believe this is a very important enzyme to protect us against oxygen toxicity. In the historical review, we looked at the concerns that Lavoisier had expressed, the early work of Dr. Baer, and the documentation of oxygen seizures. Now, a single exposure to HBO could probably be tolerated for a person even on a medication like Antabuse. And again, when we look at oxygen toxicity, we'll look at some of the protective steps that we could take. There are medications that could be provided, air brakes, and so on. So Antabuse, again, in summary, it is an absolute contraindication, probably if multiple HBO sessions are going to be provided. However, if you use aggressive medical management for oxygen toxicity with drugs like Valium and Antabuse that we will talk about later, one could presumably proceed with treatment if the clinical circumstances warranted. The next medication is sulfamylon, or mefenide. This is a carbonic anhydrase inhibitor. Now, we talked about carbonic anhydrase in the physiology session. Carbonic anhydrase is a very important enzyme in normal physiology because it allows the rapid conversion of carbon dioxide, the gas, into bicarbonate, the solid. And the solid state transfer of carbon dioxide is far more efficient and protects us from possible CO2 embolism. If a patient is on this medication, sulfamylon, it is possible that you can affect carbonic anhydrase activity. Now, sulfamylon is an antibiotic cream. It's typically not used too often in general practice. Where it is used, oftentimes, though, is in burn centers. And it's precisely the burn patient that is at increased risk to absorb significant amounts of sulfamylon because they have a large surface of burn. With all the exposed tissue, the absorption rate is far higher. So I would imagine if a patient has a very small ulcer, that sulfamylon would not necessarily preclude HBO. Nonetheless, though, I would feel more comfortable if we simply discontinue that antibiotic cream and used any of a half a dozen others that are certainly available. Silvadene, for example, commonly used in practice, would be an excellent substitute. The next absolute is a patient with a history of spontaneous pneumothorax. Now, this is a patient who will tell you that at some point in the past their lung just spontaneously collapsed. Perhaps they were in a movie theater and suddenly had some chest pain, presented to the emergency department where an x-ray was taken, and much to their surprise, they discovered their lung had collapsed. And the problem with spontaneous pneumothorax is that it is a congenital anomaly of the lung. That is to say, there is an inherent defect in the lung. Typically, it will have cysts and blebs. These things can rupture at any particular point in time. And when they rupture, they, of course, are associated with a collapse of the lung or a pneumothorax. Now, there is, of course, an ongoing risk of reoccurrence. The reoccurrence is quite substantial. In fact, about 50% of these patients will have a recurrent pneumothorax in the next 2 years. Has a fairly high association with cigarette smoking as well. Now, even with the treatment of a pneumothorax, which typically involves medical management, like pleurodesis, a scarring, or surgical tacking of the lung, there still, though, is this ongoing risk of rupture of these congenital blebs. Now, surgical management certainly is very effective, but there's concern that if a patient were to rupture a bleb, even a very small area could re-expand, again, in accordance with Boyle's law, and we could develop a tension pneumothorax, because with each atmosphere, we are exerting 14.7 pounds per square inch. And with that kind of force, even the best surgical tacking may possibly be torn and ripped away, inducing a potential life-threatening tension pneumothorax. Now, it is a relative contraindication, however, in a multiplace chamber. As you saw earlier in our opening sessions, in a multiplace, you can actually go into the chamber, listen to the chest, make a presumptive diagnosis of a pneumothorax, and place a needle in there by decompressing. But in a monoplace, there's no way we can reach that patient to touch them. And any attempt to return to the surface, again, Boyle's law, the gas can expand further, causing compromise and producing a very serious situation. So, spontaneous pneumothorax, considered to be an absolute contraindication in the setting of a monoplace chamber, but in a multiplace chamber where we can reach the patient, one certainly could proceed with treatment. So, if you have a patient with a history of spontaneous pneumothorax, you may wish to refer them to a multiplace facility in your region. Now, this is also considered to be an absolute contraindication for scuba diving. I occasionally reference this thing about diver clearance because many of you now, being involved in hyperbaric therapy, you will probably be one of the most knowledgeable individuals in your community. And accordingly, scuba divers may seek out your knowledge and expertise and look for dive clearance. And if a diver has this history of spontaneous pneumothorax, again, sports scuba diving is certainly not necessary or essential. And even though it may be a small risk, a remote risk, should any diver have an unfortunate occurrence of a pneumothorax at depth, the attempts to return to the surface could prove fatal. Now, in contrast to a history of spontaneous pneumothorax, a patient with a history of deserved pneumothorax is acceptable for hyperbaric oxygen treatment. So let's just draw on a case illustration here. Let's say that you have a 45-year-old male. He has a non-healing diabetic ulcer. As you proceed through the history, you ask him if he's ever had any kind of health problems. He said, "Well, yes, doctor, I have. When I was 18, I had a motorcycle accident. I cracked a couple of ribs. They said I collapsed my lung. Look here, I've actually still got the scar." Well, that's what we would call a deserved pneumothorax. We understand why that lung collapsed. Let's say that you're talking to another patient. This one is 65 years of age. They're suffering from chronic refractory osteomyelitis, another indication for HBO. In the course of the history, you ask if you ever had any kind of medical problems, and they say, "Well, yes, actually a couple months ago, they were putting in one of those special lines in the neck. I think you doctors call it a central IV. And in the process, they said my lung collapsed. They were putting this IV in so that I could get my antibiotics to treat my osteomyelitis." Well, again, we understand why that patient collapsed a lung having a central line placed. So these are examples of what we call deserved pneumothoraces. Once that pneumothorax is resolved, then certainly HBO can be provided. And that's in sharp contrast to the congenital anomaly of a spontaneous pneumothorax. So again, the presence of a spontaneous pneumothorax would be an absolute contraindication in a monoplace, but a relative contraindication in a multiplace. All patients with deserved pneumothoraces, though, certainly could be treated with HBO, and even with a ongoing pneumothorax, if they've had a chest tube put in, as we commented earlier, this too could actually be treated. So that really concludes our list of absolutes. So now what we're going to look at is what I simply call relative risks. Not even contraindications, just relative risks that you should keep in mind. And the first one we're going to look at are patients who have had carbon monoxide poisoning so severe that they required CPR, cardiopulmonary resuscitation. And in this report, published in the American Journal of Emergency Medicine, the authors looked at 297 consecutive cases of CO poisoning. And they noticed that when CPR had been provided, that the incidence of a tension pneumothorax for patients on the ventilator was as high as 12%. Now that's 1 in 10 patients. It was high enough that the authors commented that prophylactic chest tubes should probably be provided for anybody who's had CPR and being placed in a monoplace chamber. Now again, if you have a multiplace chamber, one could certainly do needle decompression should this occur, but with a risk of 1 in 10, even there you might wish to consider that. Now the next relative risk to consider are patients who have a history of thoracic surgery. Oftentimes in textbooks you will read authors expressing concern that with prior thoracic surgery there may be a risk. Well, the concern is certainly understandable, but I find that oftentimes that kind of concern is simply too general of a concern. Certainly it's good advice to always be cautious. When I get out of bed in the morning, I suppose it's good to be cautious. And certainly with a history of chest surgery, it's good to be cautious. My personal case experience treating many patients with peripheral vascular disease, which of course has the associated coronary disease, and back in the 1980s with many of these patients getting open coronary bypass grafts, really had no untoward problems. So again, this is sort of a general unqualified concern. As you read these things in textbooks, it's sometimes difficult when you're new to a field to know how big of a problem is it. And again, I think it's sort of an unqualified concern. One should always look at a chest x-ray and just use good clinical sense in approaching these patients. Certainly using slow ascent rates at 1 pound per minute is useful. Now, on this matter of ascent rates, the typical ascent rate that's used at many programs is 1 pound per minute. So oftentimes what is done is we compress at 1 pound per minute going to 2 ATA and decompress at 1 pound per minute coming back from 2 ATA. Sometimes at higher pressures people may wish to accelerate the compression some. Now I know we have yet to even talk about indications, but it's useful at this particular juncture to draw on another piece of that puzzle I spoke of earlier in putting together the big picture of hyperbaric therapy. Another relative risk to think about would be any patient who has an abnormality on X-ray or CT scan. Again, the concern here is that if you have some pneumatoceles or blebs or bulli, that these could possibly trap air. Again, in accordance with Boyle's law, the gas, if it cannot escape easily, could expand, resulting in possible rupture. So the central question really is whether or not that bolus ventilates properly. Now this can sometimes be problematic. Sometimes people will use detailed CT scans. That can be useful. Xenon lung scans where you inhale a radioisotope and then you wait to see it clear. If the bleb is not clearing the isotope, it suggests one of two things. Number one, there could be air trapping, and certainly number two is there could just simply be poor ventilation. That is to say, it is open, but it doesn't ventilate well and not necessarily trapping. Consultation with your pulmonologist can also be useful in gaining further insight. And at the end of the day, you'll just have to make a clinical decision. After all, in this business, they don't give us a crystal ball. Let's move on to another area also related to the lung. And this would be patients with obstructive lung disease. Now, in this category, we have a number of considerations. We have patients who have asthma. That certainly is a form of obstructive lung disease. And then we also have our patients who have COPD, chronic obstructive pulmonary disease. In this category, there really are two types of COPD. The first is what we sometimes refer to as emphysematous disease, and the other is bronchitic disease. In medical school, I was taught the colorful metaphors of the pink puffer and the blue bloater. So let's take a minute here and examine this topic a little more closely, because a lot of your patients, certainly being seen in the wound healing center, have had a prior history of smoking. After all, it's the smoking that brings on the peripheral arterial disease that ultimately results in the slow, chronic, non-healing wound and a hypoxic wound bed. So following your transcutaneous studies, you may wish to employ hyperbaric therapy as part of their management, but there may be concern regarding the severity of their lung disease. Now, patients with COPD, as I mentioned, can be divided in those two broad categories. For the patient with emphysematous disease, sometimes called vanishing lung syndrome, these patients have a problem with oxygenation, but they seem to ventilate pretty well. That is to say, their CO2 levels are normally within the acceptable range of about 40. They just have problems with oxygen. 2 liters of oxygen promptly corrects that. So these patients usually are acceptable from a risk perspective for HBO. Again, one would want to get chest x-rays and consider a few other aspects. But it's the blue bloater where there is greater concern. These are individuals who not only have problems with hypoxia, but they also have problems with hypercapnia. That is to say, they have a ventilatory problem. Now, in looking at these patients, certainly the concern about the hypercapnia is that if you give them too much oxygen, they may stop breathing. Or do they? So let's examine this concept a little more closely. What's traditionally been taught in the past is as you begin to develop higher and higher CO2 levels, the patient habituates. That is to say, carbon dioxide no longer becomes a stimulus to breathe. There are two things that really drive respiration. One is hypercapnia, carbon dioxide, and the other is hypoxia. So as they become habituated to the higher and higher levels of carbon dioxide, now the primary stimulus or drive to breathe is really oxygen. And the concern is if you give them too much oxygen, you stop them breathing. Why, I've had paramedics bring patients to the emergency department with severe COPD, and they don't give them oxygen. I ask why. Oh, well, doc, I don't want to stop them breathing. Of course, I look at the patient, they're kind of blue. I say, you know, they're not looking too good right now. So in the back of an ambulance, you are in constant attendance, and if the patient is cyanotic, then you should give them oxygen. So where the real concern is in the long-term medical setting. So let's say the patient with COPD is admitted to the hospital. They have an elevated PCO2. They're put on oxygen, a higher dose of oxygen than they're normally accustomed to, and the nurse leaves the room. Now, when will he or she be back? Well, it could be 4 or 5 hours later. They've got a lot of other patients to see, and in that interval, because of the higher oxygen they're being exposed to, they no longer breathe as frequently. So their respiratory rate had formerly been 16 per minute, now declines to 12 per minute. And because they're breathing a little slower, their CO2 rises even further. Now, the effect of hypercapnia, even higher CO2, is one of sedation. With the sedation, they become more drowsy. Their respiration declines even further to perhaps 10 per minute. Now, when the nurse comes back, what they might find is a patient who's sitting there snoring, and that is the concern. So here's the point. Providing oxygen does not render your patient apneic. It doesn't stop breathing. What it does do is it depresses respiration. And the concern is if you leave the patient unattended. Now, in the hyperbaric unit, we certainly are not going to leave these patients unattended. So how then should we approach these individuals? Well, my approach is, number one, look at your medical record. Certainly anybody with severe COPD has probably had an arterial blood gas. If they haven't, I would doubt they warrant the diagnosis of severe COPD. But let's just say, for purposes of discussion here, that you do have a patient you are concerned with, you get that arterial blood gas. If the arterial blood gas comes back in the range of, say, 50 or 55, you might be a little worried. So what should you do next? Well, what I do for these patients is I give them an oxygen challenge. Now, not the kind of oxygen challenge we talked about with transcutaneous mapping. What I do is I put them on 100% oxygen, park them in the corner, and I have them read a magazine for about an hour. I usually sit down with the patient first to explain why we're doing this. I tell the patient, you know, this may sound strange, but you know you've got problems with your lung. Oh, I know that, doctor. And your lungs may get so much oxygen, they don't know what to do with it. So we're just going to check and see how well you can tolerate this oxygen. And so I'll park them in the corner. And if I look over there and 45 minutes later, they're kind of flipping through that magazine and they say, well, Dr. Bartlett, are you about done? Well, that's a patient who's probably going to do okay. On the other hand, if I look over there in 45 minutes and they're kind of bobbing their head, well, that's a patient who perhaps is getting hypercapnic, sedated. And what I'll typically do then is I wake them up. Mr. Jones? Oh, what? Mr. Jones, looked like you fell asleep. That's a person who's getting too much oxygen. Now, in conducting this kind of oxygen challenge, I think it's probably best done with a patient on an EKG monitor to make sure they don't become bradycardic, and also a pulse ox to make sure the oxygen value is certainly in the normal range. Because what you don't want to do is promptly stop the oxygen. Keep in mind the patient is somewhat sedated, they're breathing a little slower, and under the slowed respiration they could rapidly desaturate. So you simply dial down that oxygen, continue to monitor the pulse ox, and they will, of course, wake up promptly. Now, there are times where you may have individuals who have such severe COPD, you wouldn't even engage in a challenge like this. Let's say, for example, you have a person who's been admitted to the hospital 3 times in the last 18 months, been on the ventilator twice, the last time they had a DNR order. Well, of course, this patient, really, the risk is far too high. And a lot like the general surgeon who gets an internal medicine clearance, you wouldn't take that patient to the OR, and we certainly wouldn't take a case like that to the hyperbaric chamber. So in clinical practice, then, how often do you really expect to run across this? Well, in my 25 years, I'll tell you that most of the patients that have a history of COPD, in fact, when you look at their records, it is a diagnosis, but not to the point their physiology is so compromised they are hypercapnic. Then the other category, of course, are patients who have such severe disease that you don't need to do an oxygen challenge. These patients certainly would not be a candidate, but every once in a while you get the rare case where they have a compelling indication for HBO and you'd like to give them hyperbarics, but you're just not comfortable enough. Again, this kind of oxygen challenge can be an excellent way to test their ability to withstand a very high exposure to oxygen and to do it safely before they're in the hyperbaric chamber. Well, let's turn now to the next area of obstructive lung disease, and that's asthma.